Bismillahirrahmanirrahim. Assalamu alaikum, dear students. Dr. Rizwan here from the Department of Biochemistry, Independent Medical College, Faisalabad. Today we will discuss our next fat-soluble vitamin, that is vitamin D. Vitamin D is a fat-soluble vitamin. It resembles a sterol in its structure and function like a hormone. Vitamin D is absorbed in the small intestine, for which bile is essential. Through the lymph, vitamin D enters in the circulation and bound to the plasma alpha-2 globulins and is distributed throughout the body. Liver and the other tissues store small amount of vitamin D. Vitamin D2 and vitamin D3, they as such are not biologically active. They are metabolized identically in the body and convert into its active form of vitamin D. The dietary sources includes the fatty fish, fish liver oils, egg yolk sac, and vitamin D can be provided to the body in three ways. Number one, exposure of the sunlight for the synthesis of vitamin D. Number two is the consumption of natural foods. And number three, by the irradiating the foods like the yeast that contain precursors for the vitamin D and fortification of foods. Vitamin D are a group of sterols that have hormone-like function. The active molecules are 1,25-dihydroxycholecalciferol. It is also known as vitamin D3. The 1,25-dihydroxycholecalciferol binds to intracellular receptor proteins. 1,25-dihydroxycholecalciferol D3 receptors complex interacts with the DNA in the nucleus of the target cells in a manner similar to that of vitamin A, and either selectively stimulates gene expression or specifically repress the gene transcription. The most prominent action of 1,25-dihydroxycholecalciferol are to regulate the plasma levels of calcium and phosphorus. The distribution of vitamin D in the diet is the ergocalciferol. It is found in the plants, and the cholecalciferol, it is vitamin D3, it is found in the animal tissues. These are the sources of preformed vitamin D activity. Ergocalciferol and cholecalciferol differs chemically in the presence of an additional double bond and a methyl group which is present in the plant sterol. The endogenous vitamin precursors are the 7-dehydrocholesterol. It is an intermediate in the cholesterol synthesis. It is converted to cholecalciferol in the dermis and epidermis of the human, which is exposed to the sunlight. The preformed vitamin D is a dietary requirement only in the individuals with limited exposure to the sunlight. And regarding the metabolism of vitamin D, the first step is the formation of 1,25-dihydroxycholecalciferol. The vitamin D2 and vitamin D3 are not biologically active, as I have discussed earlier, but they are converted into active form of vitamin D by the two sequential hydroxylation reactions. The first hydroxylation reaction occurs at the 25th position and catalyzed by a specific hydroxylase in the liver. The product of this reaction is 25-hydroxycholecalciferol. It is a predominant in the form of vitamin D in the plasma and the major storage form of vitamin. It is further hydroxylated at the position 1 by a specific 1-hydroxylase which is found primarily in the kidneys resulting in the formation of 125 dihydroxycholecalciferol. And the second step is the regulation of 25 hydroxycholecalciferol 1-hydroxylase. The 125 dihydroxycholecalciferol is the most potent vitamin D metabolite. Formation is tightly regulated by the level of plasma phosphate and calcium ions. The activity of this enzyme, that is 25 hydroxycholecalciferol 1-hydroxylase, it is increased directly by the low plasma phosphate level or indirectly by the low plasma calcium, which triggers the release of parathyroid hormone. Hypocalcemia caused by insufficient dietary calcium results in elevated level of plasma 125 dihydroxycholecalciferol. Regarding the sum of the functions of vitamin D, the overall function of 125 cholecalciferol, which is also known as D3, is to maintain the adequate plasma level of calcium, and the functions are performed by increasing the uptake of calcium by the intestine, minimizing the loss of calcium by the kidneys, and stimulating the reabsorption of bone when necessary. The effect of vitamin D on the intestine: it stimulates the intestinal absorption of the calcium and phosphate. It enters into the intestinal cells and binds to a cytosolic receptor. This complex then moves to the nucleus, where it selectively interacts with the cellular DNA. As a result, calcium uptake is enhanced by an increased synthesis of a specific calcium binding protein. This mechanism of action of 125 cholecalciferol is atypical, like a steroid hormone. Number 2 is the effect of vitamin D on the bone. It stimulates the mobilization of calcium and phosphate from the bone by the process that require protein synthesis and presence of parathyroid hormones. The result is an increase in plasma calcium and phosphate level. Thus, bone is an important reservoir of calcium that can mobilize to maintain the plasma levels of the calcium. The action of calcitriol on the kidney it is also involved in minimizing the excretion of calcium and phosphate through the kidney by decreasing their excretion and enhancing the reabsorption. The sequence of events that takes place in response to the low plasma calcium concentration and the action of calcitriol on intestine, kidney and the bones, ultimately leading to increase in the plasma calcium level. The distribution and the requirement of vitamin D. Vitamin D occurs naturally in the fatty fish, liver and egg yolk sac. Milk, unless it is artificially fortified, is not a good source of vitamin D. The recommended dietary allowances for the adults and the children are 200 and 400 international units respectively of the vitamin D. In pregnancy and lactation, the requirement is 400 international units per day. Now we'll discuss some clinical conditions which are associated with the vitamin D. One is the nutritional rickets. Vitamin D deficiency causes a net demineralization of the bone, resulting in the rickets in the children and osteomalacia in adults. Rickets is characterized by continued formation of a collagen matrix of bone, but incomplete mineralization resulting in the soft, pliable bones. And on the other hand, osteomalacia is a demineralization of pre-existing bones, which increases their susceptibility to fracture. In insufficient exposure to daylight or the deficiency in the vitamin D consumption occurs predominantly in infants and elderly. Vitamin D deficiency is more common in the northern latitudes because the less availability of and the less of the sunlight and the deficiency in the synthesis of vitamin D as a result of reduced exposure to sunlight and ultraviolet rays. Now in this flow sheet diagram, the 7-dehydrocholesterol which is present in the skin, which is being transported and activated when the ultraviolet rays which are attached on the skin, it converts into cholecalciferol, and the dietary supplements of vitamin D are the cholecalciferol and the ergocalciferol. These are the plant and the animal source. Now these forms, they are transported into the liver where the first hydroxylation reactions takes place at 25th position, which converts it into 25 hydroxycholecalciferol. Now this 25 hydroxycholecalciferol is taken up to the liver where the second hydroxylation reactions takes place at position 1, resulting in the formation of 125 dihydroxycholecalciferol and some inactive metabolites of vitamin D. And this, the active form, that is also known as the calcitriol, it increases the intestinal absorption of calcium, it increases the bone resorption and decreases the renal excretion of calcium and phosphate ions. Now we'll discuss the deficiency consequences of vitamin D. It reduces the intestinal absorption of calcium and phosphorus. Hypophosphatemia precedes hypocalcemia and the secondary hyperparathyroidism. The important feature is the bone demineralization, which results in osteomalacia and rickets. Now we'll discuss the deficiency symptoms which are related to vitamin D. The first symptom which appear in the children is the rickets. It is a disease primarily due to the deficiency of vitamin D in the diet and the sunlight. The deficiency of vitamin D results in low plasma calcium level. This stimulates the secretion of parathyroid hormones, which restores the plasma calcium at the expense of bone calcium. Here are some conditions which are associated with the vitamin D deficiency. The first is the ricket. It is the defective mineralization of growing bone before epiphyseal fusion. And the second condition is the renal osteodystrophy. It is also known as the vitamin D resistant ricket. It is the alteration in the skeletal growth and remodeling in the chronic renal failure. Osteomalacia, it is a defective mineralization of the bone after epiphyseal fusion. Osteoporosis, it is a proportionate loss of bone volume and minerals. Osteopenia of prematurity, it is a postnatal inadequate bone mineralization in preterm babies. Now there are the two types of rickets. One is the vitamin D dependent ricket type 1. This is the autosomal recessive disorders which results in the mutation in the gene encoding renal 1 alpha hydroxylase, preventing the conversion of 25 dihydroxycholesterol into 125 dihydroxycholesterol, which is present during the first 2 years of life. The classic features of rickets including the symptomatic hypocalcemia. They have normal levels of 25 dihydroxycholesterol but low levels of 125 dihydroxycholesterol. The vitamin D dependent rickets type 2. In it, there is a mutation in the gene encoding the vitamin D receptors. The levels of 125 dihydroxycholecalciferol are extremely elevated. It is an autosomal recessive disorder and the most patients present during infancy, although the less severe affected patients may not be diagnosed until adulthood. The less severe disease is associated with particularly the partially functional vitamin D receptors. 50 to 70% of the patient it presents with the alopecia. And the second deficiency symptoms of the vitamin D is the osteomalacia. It means the softening of the bone. The formed bones get demineralized and become soft. The repeated pregnancies are one of the cause of this osteomalacia. There is a negative calcium balance due to a load of pregnancies. It particularly affects the pelvic bone, which bear the stress in the pregnancy. The pelvic bone become narrow and deformed and further complicated the childbirth. The lab tests which are important for the diagnosis of this osteomalacia is a low level of calcium and phosphate, and on the X-ray we will find the diffused bone lucencies. The associated clinical conditions with the vitamin D deficiency is a muscle weakness and history of falls. Proximal muscle weakness, chronic muscle aches, myopathies, increase in the history of falls. The recent studies suggest that vitamin D supplementations at the doses of 700 to 800 international units in a vitamin D deficient elderly populations can significantly reduce the incidence of falls. Regarding the bone densities and the fractures, the risk of osteoporosis may be reduced with adequate intake of vitamin D and the calcium. The studies support the concept that the vitamin D at the dose between 7 to 800 international units per day, along with the calcium supplementation, effectively increase the hip bone density and reduce the fracture risk, whereas lower vitamin D doses may have less effect. Role in the cancer prevention. The low intake of vitamin D and the calcium has been associated with an increased risk of non-Hodgkin lymphomas, along with the cancer of colon, ovarian cancers, breast cancer, prostatic cancer, and other cancers. It has also shown the anti-cancer activity, a nuclear transcription factor that regulates cell growth, cell differentiation, and apoptosis, and is central to the development of a cancer. Role in cardiovascular diseases. Vitamin D deficiency activates the renin-angiotensin-aldosterone system and can predispose to the hypertension and left ventricular hypertrophy. Additionally, vitamin D deficiency causes an increase in the parathyroid hormone, which increase in insulin resistance, secondary to the downregulation of insulin receptors, and is associated with the diabetes, hypertension, inflammation, and the increased risk of cardiovascular diseases. Here are some investigations to rule out Number first is the renal function test, liver function test, parathyroid hormones, the levels of calcium, phosphates, alkaline phosphatase, and the level of 25 hydroxy vitamin D concentrations or the vitamin D3 levels. These are the possible consequences of vitamin D deficiency, which are summarized in a single diagram. And because on the left hand, these are the causes due to the uh, deficiency of vitamin D, resulting in the consequences which are shown on the right side of the picture. Using of sunscreens due to the medication and supplements, and due to the malabsorption syndromes, there is deficiency of vitamin D, like uh, excessive use of glucocorticoids, rifampicins, highly active antiretroviral treatment in hepatic failure, renal failure, and the nephrotic syndrome. The same in the malabsorption symptoms like Crohn's disease, Whipple's disease, cystic fibrosis. The deficiency of vitamin D occurs, which results in uh, some infections like influenza, tuberculosis, and some lung diseases and autoimmune diseases like uh, type 1 diabetes and Crohn's disease. And the deficiency systems also increase the risk of cancers like breast cancers, cancers of colon, prostate, pancreas, etc. Thank you, students. Now read it also from your textbook. I hope you will understand regarding the vitamin D, its function, its storage, its and the deficiency diseases. We will discuss the next fat soluble vitamin inshallah in the next lecture. Okay, Allah Hafiz.